We're going to talk acute kidney injuries. Real quick, so just an anatomy review of our kidneys, right? So we've got our kidneys, they're going to filter blood, they create urine, so excretion, and then reabsorption. So there are three functions: our filtration, reabsorption, and excretion. We have two ureters that are going to transfer urine to our bladder. Our bladder is a reservoir. It stores urine. It's made of smooth muscle tissue. And then our urethra, which is going to empty our bladder so we can void or excrete our urine. So here's a picture, right? Our kidneys, okay, they're fed by the renal vein, the renal artery, and our renal vein, ureters, bladder. Here's inside, we got our renal medulla, which is going to hold all of our nephrons. We have millions of nephrons. Each nephron has millions of glomeruli in them, so we have lots of filtration. Our kidneys are able to filter our entire blood volume within about 5 minutes. So every 5 minutes, which is kind of crazy. About 125 mils a minute is normal filtration rate. So again, urine formation and waste excretion. Our kidneys are really important for regulation of our fluid status, our electrolytes, our blood pressure, as well as our red blood cell production through releasing erythropoietin when it senses hypoxia, synthesis of vitamin D to calcitonin, which is then the active form of vitamin D, which is what we use to bring calcium into the bones, and then secretion of some of our prostaglandins. Okay, and then again, our nephrons. Each kidney has millions of nephrons. Alright, and they're going to filter blood using our glomerulus, so filtration through our Bowman's capsule, and then we're going to have reabsorption and secretion through all of our different tubules. So we have our proximal tubule, our loop of Henle, and our distal tubule. So here's a picture of, in here, this is like our Bowman's capsule. Right, we're going to have a crossing of filtrates, some proteins, some amino acids, some hormones, some vitamins, ketones, hydrogen ions, all that good stuff, glucose. And then as this filters through, down through our tubules, we exchange either water or any of these other organic compounds. What you will see is things like red blood cells, large proteins, leukocytes, erythrocytes. They should not be crossing through this capillary membrane. Okay, so blood's going to enter from one artery into our afferent arteriole, into Bowman's capsule, out our efferent. Alright, and then we're going to go through in our peritubular capillaries, okay, through our proximal convoluted tubule, where we pick up a lot of our hydrogen ions, amino acids, and glucose, which will enter back into our bloodstream. We get water re-entering through the loop of Henle, and then sodium entering through the ascending loop, and then the distal convoluted loop is kind of like our finishing touch. Think of like in the car wash when you're at the end, and finishing touches, right? This is where they're gonna add the shine. Okay, manage our electrolytes, manage our acid base, then collecting tubules is where our urine's gonna be. And so here's just another picture of it. Oh, an acute kidney injury. Biggest thing is acute here, all right? This is something that happens rapidly. We can have a patient who has chronic kidney disease, and they can have an acute kidney injury. So, right, we're going to have an acute rapid loss of kidney function. So even if they have a GFR of 30 and now their GFR is 10, right, even though they have chronic kidney disease, it's an acute kidney injury. So with an acute kidney injury, our hope is that we can get some of that function back. Where in chronic kidney disease, it's a little harder to almost impossible to get any function back. So we're going to develop azotemia, which is just increase of waste products, so our nitrogenous waste, so our urea, right, which we measure with our bun. and then our creatinine, which we measure with our creatinine, and then an increased potassium. Criteria is at least an increase of 50% from our baseline serum creatinine. So this is why it's important. We're looking at our patients' labs, if possible, to look at labs from previous visits, especially if we can get like their primary care lab work to see where they are. So if they're at a 0.6 usually, right, even like 50% would be like a 0.9, or if they're at a 1 usually, and now they're at a 1.5. Oliguria, so less than half a mil per kg per hour, or less than 400 mils a day. And they just need one of these. They don't need all three of them, or anuria. So if we're making less than 50 mils a day, these are indicative of an acute kidney injury. An acute kidney injury can be prerenal, intrarenal, or postrenal. Our most common is going to be the 60 to 70% of the time. It's going to be a prerenal injury. So this is as a result of hypovolemia, decreased renal perfusion, or like intense vasodilation, so like sepsis. Our intrarenal is going to be prolonged renal ischemia from some of like our medications, mostly nephrotoxic agents. So if we think like NSAIDs, a lot of our antibiotics, or infective processes within the kidneys, so such as like polycystic kidney disease, hydronephrosis, those types of infections. And then post-renal is going to be from like a urinary tract obstruction. So if we think like renal, like a renal calculus, like kidney stones, prostate hypertrophy, those types of things. So our prerenal causes, again, these are going to be our most common. A reduction of blood flow to the kidneys causing a decrease in perfusion to our glomerulars. Right, our kidneys are very, very finicky. They like to have a lot of blood, right? 25% of our cardiac output goes to our kidneys, right? This is why we have to have that map of 65 to protect our kidneys. So this hypovolemia, so this can be from decreased cardiac output, right? Hypovolemia, think hypovolemia to the kidneys. Okay, those renal arteries are pretty little, so if we have vasoconstriction because of hypotension, right, we're going to constrict those renal arteries, we're going to have decreased blood flow to the kidneys. Decreased cardiac output, so our patients who are in heart failure, right, we can actually worsen our heart failure, release that RAS system to the kidneys, which is going to put more workload on the heart, which is going to worsen our perfusion to the kidneys, and they're going to continue to release renin, worsening our heart failure. So we kind of develop this very vicious cycle. We can see acute kidney injuries, especially after like an MI or some sort of episode where we have significant decreased cardiac output. Dehydration, especially from like GI loss. So our nausea, vomiting, diarrhea, these patients who are hypovolemic, again, because of dehydration, or hemorrhage, of course, right? Hypotension, and then some sort of vascular obstruction. So if we have a clot, say, in the renal artery, or if we have a bunch of atherosclerotic buildup in the renal artery, we can develop an aneurysm in our abdominal aorta, which can cause a blockage to the renal artery. So all of these are prerenal causes. We can also see prerenal causes sometimes with like burns, just related to that dehydration. Burns can also be an intrarenal cause of acute kidney injury. So our intrarenal damage or intrarenal injury is direct damage to the renal tissue. So this could be like trauma to our kidneys, right? Like somebody gets stabbed in the kidney. Not great. It's going to result in impaired nephron function. So we can see from prolonged ischemia. Mostly we're going to see this ischemia from like nephrotoxic agents, such as our antibiotics. Contrast dye is a really big one, right? Whenever we give a patient like a CT with contrast, an MRI with contrast, and then we're going to do another contrast study, and now let's send them to the cath lab and give them more contrast. We really want to watch those kidneys for an acute kidney injury. And then our NSAIDs, so our ibuprofen, our Aleve, our aspirin, right? They're nephrotoxic. Hemolysis. So hemolysis is we're going to have that destruction of our red blood cells. Okay, those red blood cells are filtered out in the kidney. And if you guys remember going back to that picture of the Bowman's capsule, right, red blood cells are still pretty big, and they're going to be kind of tearing through that membrane, which can cause some ischemia to our little glomerules. We can have hemolysis after a blood transfusion. We can have it with sepsis and some of our other chronic conditions. And then myoglobin. So myoglobin is going to be a result of necrotic muscle cells. So we talked in rhabdomyolysis about how when our muscles break down, they're going to release myoglobin. And myoglobin is really hard on our nephrons and can cause an intrarenal acute kidney injury. Okay, when we have an acute kidney injury related to muscle breakdown, right, that's our rhabdomyolysis, high morbidity and mortality rate. And then acute glomerular nephritis. So this can be from just nephritis, this can be from our hydronephrosis, right? This is our kidney infection, right? Our infective agents inside the kidney. And then post-renal is some sort of mechanical obstruction. So something is causing reflux into the renal pelvis, which is going to cause this hydronephrosis. So we'll have a post-renal and an intrarenal acute kidney injury, right? We can have all three if we had to. Renal calculi, so kidney stones, right? We're going to block the output of urine. That urine is going to back up into the kidneys, cause some nephron ischemia. We can see this from prostate cancer. We can see this from trauma, like a broken pelvis, okay, as well as tumors in the urinary tract. A really bad UTI can also cause a post-renal acute kidney injury. So here's our classification. So we've got rifle, risk, injury, failure, loss, end-stage kidney disease. So risk, right, risk is going to be a decreased urine output, but not for very long. Our creatinine's 1.5 times its baseline, and so our GFR is going to decrease by 25%. A risk for an acute kidney injury, we might see this after like a heart cath, right? After being exposed to some contrast, we're able to hydrate them, we're able to wash out those kidneys, and we can get some function back. Next is going to be injury. So our creatinine's doubled, and our GFR is in half. Decrease urine output again, but for a prolonged period of time. All right, and this is less than 0.5 mils per kg. Okay, for a prolonged period of time. These patients are going to need to probably stay a couple extra days in the hospital, right after, say, like their heart cath. Okay, we want to get that creatinine back down to baseline before we send them home. Again, lots of fluids. We could give diuretics, right? Diuretics, especially like our loop diuretics, actually increase blood flow to our kidneys to help increase perfusion, help decrease that injury. Failure. So failure, we have a reduction in GFR of 75%. All right, we are 3 times the baseline of our creatinine, okay, or greater than 3.5. All right, we're having significant decrease in urine output, or we're anuric. We're not making any urine for 12 hours. This is kidney failure, right? These are patients that we look at and we think, are they going to need temporary dialysis? Do they need continuous renal replacement therapy? Right, these guys are pretty sick. Because not only, right, so when we have this increased creatinine, we're holding on to all of those waste products, right? We're going to have elevated potassium. We're going to have a metabolic acidosis. Loss is when we have these failure symptoms for greater than 4 weeks. Okay, and if that continues for 3 months, we just consider that end-stage kidney disease. And these patients are now on chronic kidney disease. Okay, they now have a chronic condition related to an acute injury. All right. A lot of this is preventable if it's caught early, but that's what's hard is we have to catch it early and treat it early, and avoid those nephrotoxic agents. And if we think back to a little bit of pharm about how many of our meds are nephrotoxic, right? How many of them have renal clearance and renal metabolism? That's just putting extra workload on the kidneys, increasing our injury and our risk. So we have phases. So these are the classifications, right? We went over the classifications of a kidney injury. Then we have the phases. So initiation, oliguria, diuresis, and recovery. So the initiation phase, right, this is like our initial injury, right, our initial insult to the kidney. We have a reduction in renal blood flow and oxygenation. So even our patients who are hypoxic, our patients who are hypotensive, 25% reduction in circulating volume. So our patients who are dehydrated, they're hypovolemic, our patients who are hemorrhaging, right, after a surgery. We're going to compensate by activating that RAS system and releasing vasopressin and norepinephrine, right? So we're going to try to increase renal perfusion by vasoconstriction and fluid retention, vasoconstriction, fluid retention, and vasoconstriction. One of the signs of the initiation phase is just a decrease of urine output, right? We're going to have a higher specific gravity within our urine because we're holding on to more fluid, and when we hold on to water, we hold on to sodium. So our urine's going to be more concentrated and less salty because we're going to be holding on to more fluid. Next is our oliguria phase. So this can be within 1 to 14 days after an injury. The longer we're in this phase, the poorer our prognosis. All right, not all of our patients are actually considered oliguric, right? Not all of them are making less than 400 mils of urine a day, or less than that half a mil per kg per hour, but we have symptoms of fluid volume excess. So peripheral edema, crackles in the lungs, higher oxygen needs. Okay, they might hear a murmur. All right. Increased BUN and creatinine. We will not necessarily have changes in our specific gravity at this point. Okay, urine will be a little salty, but our specific gravity in our urine should be the same. Increased potassium. We're going to have a decreased in GFR. Then again, half of these patients will have symptoms of oliguria, but the rest will have these symptoms of fluid volume excess and increase in our nitrogenous waste and increased potassium. Then we're going to be in our diuresis phase. All right, so this is going to be when we're finally getting rid of all of that fluid we've been retaining because our kidneys thought that we were dying because they weren't getting enough oxygen and they were being perfused. All right, these guys can be peeing out like 1 to 5 liters a day, which is pretty significant from less than 400 mils a day. They're going to have a low osmotic urine, right? We're not able to concentrate our urine. We're peeing out a lot of water. So these guys are a really high risk of dehydration and electrolyte imbalances, right? They're a risk for hyponatremia, hypokalemia, and our dehydration, which can put them back into that injury phase. So if we go back to like our rifle, so like they're already at risk, and then injury, it can put them back at injury if we're dehydrated. So we really want to watch these guys and maybe gently hydrate them, encourage oral intake, right? Drink when they're thirsty. But our BUN and our creatinine are still going to start to normalize. Our BUN is going to normalize first, and then our creatinine is going to trail behind about a day or two. We can have a normal BUN, and the next day maybe a normal creatinine, or 48 hours after. Then we have our recovery phase, right? This can last 3 to 12 months. All right, we're having our GFR slowly return to normal. Our BUN and our creatinine have normalized. When they have it normalized, it's when we're in that end-stage kidney disease. We will lose some GFR function though. It's normal to have like a 1 to 3% decrease in our functioning glomerulus after an acute kidney injury. So, what are these guys going to look like, right? All organ systems are affected. If we think about all that our kidneys do, okay, they're excreting waste, they're helping maintain blood pressure, they're helping maintain our red blood cell production. So if any cell needs those things, which they all do, then we're going to have some sort of effect from an acute kidney injury. These are pretty critically ill patients, so they might come in lethargic, they might come in encephalopic because we have this increase in waste, which can cause confusion. Hyperkalemia, hypocalcemia, again, because we're not making that calcitonin, and then hyponatremia, because we're just peeing everything out, or we are so fluid overloaded that we're diluting out our sodium. There'll be a metabolic acidosis, so they'll have a low pH as well as a low bicarb. They might be trying to compensate by breathing off excess CO2. So you might see some Kussmaul respirations with these patients, so a low CO2. Fluid volume overload, so crackles, maybe a murmur, peripheral edema. Okay, GI upset, nausea, vomiting, diarrhea related to this acidosis and this hyperkalemia, which is just going to get worse with nausea, vomiting, diarrhea. And then again, confusion, lethargic, right? They're going to be a little encephalopic, okay, because we're retaining all of those waste materials. So hyperkalemia can lead to life-threatening dysrhythmias, right? We can have ventricular fibrillation, ventricular tachycardia, or even asystole. We're going to see peaked T waves on our ECG, and our patient might be complaining of some heart palpitations. So if somebody comes with an acute kidney injury and they are hyperkalemic, we need to treat this first. Right? These patients are going to be placed on a telemonitor, right? They're going to be brought to like a step-down unit or the ICU, depending on what their potassium level is. They're getting close observation, and then we're going to correct it. So we can correct it with insulin, because insulin is going to push that potassium back intracellularly. If we're giving insulin, we have to be careful about their blood sugar as well. So we're going to also give IV glucagon or dextrose, not glucose, to combat any hypoglycemia. Okay, we can also give them albuterol. Albuterol can also shift potassium into the cells. Calcium gluconate, again, which can help regulate our potassium level. Kxalate is a medication we can give that's going to bind to potassium in the GI system, so we can excrete it out that way. We can give a loop diuretic, such as Lasix, right? But if our GFR is 12, okay, and our creatinine is 7, a loop diuretic is just going to make this patient worse. Right? It's going to be expecting the kidney to work harder. So we have to kind of evaluate how bad this kidney injury is. And then we can do emergent hemodialysis as well. So this is when we place like a hemodialysis line, it's like a Merherker, place a central line and put them on CRRT. All right, we're going to try to quickly remove that potassium externally with the machine. So, and then our medical management, right, we want to eliminate the cause. So if our patient is hemorrhaging and we give them Kxalate, they're still going to be having an acute kidney injury because of their hemorrhaging. So we want to eliminate that cause. All right, they've been getting nephrotoxic medication, so they've been getting vancomycin for 3 weeks for C. diff. Maybe we switch them or decrease that dose of vancomycin. We're going to want to prevent any complications. These are complications related to all of our organs that rely on our kidneys. So we're going to want to try to give them medications or create a safe environment to prevent any falls if they're encephalopic. We're going to be wanting to help out their heart, right? Reduce their cardiac workload if they're fluid overloaded. Give them diuretics. Again, maintain this fluid status. They may need to be on a fluid restriction. Dialysis, whether it's emergent, whether we're doing like actual hemodialysis or continuous renal replacement therapy, which is a little more gentle. And then managing and treating that hyperkalemia. So, where's the nurse? taking care of this patient. All right, biggest thing is prevention. Okay, this is why we want to do eyes and nose on our patients. This is why we want to be aware of what their urine output is. All right, it's been 8 hours and your patient's only peed 100 mils. Maybe we go in and evaluate. Maybe we redraw our metabolic panel. Make sure that their creatinine and BUN isn't creeping up. Making sure that they're not retaining water, right? Get a weight on them. Monitor our fluid and electrolytes. So, daily weights, up on a scale if we can. Okay, we should be comparing our weights. Strict eyes and O's. Alright, we are educating our patient and their family. If we give them anything to drink, we need to know about it. Okay, maybe a Foley catheter for these guys so we can monitor their output to the hour. Monitoring our BUN and our creatinine, monitoring our potassium level. We're going to be wanting that H&H as well, right? If they're bleeding, okay, that's one thing, as well as to watch for our erythropoietin production. And H&H is also telling us our oxygen carrying capacity. So if we cannot oxygenate our kidneys, then we're going to be worsening our kidney injury. Watching our patient's sodium. Okay, so hyponatremia we can see with an acute kidney injury because we're going to be retaining fluid. And then ABGs to monitor for metabolic acidosis. We're going to want to reduce their metabolic rate. Okay, these are guys that we're not really promoting them to get up and walk around the unit 4 or 5 times a day. Okay, we want to kind of decrease their metabolic demand to allow those kidneys just a little bit of time to heal. Promote pulmonary function. So the way our body corrects a metabolic acidosis is by creating a respiratory alkalosis, right? We're going to be breathing off our CO2. We're going to be hyperventilating. Patients can only do that for so long. So we want to try to maintain oxygenation, try to treat anxiety if we can to reduce that like their breathing workload. Infection prevention, just to make it so we're not making this acute kidney injury worse, right? They got a UTI, we don't want them traveling up into their kidneys. And then eliminating nephrotoxic medications. So again, go back to your farm of all of our meds that are nephrotoxic. There's so many. Most of our antibiotics, a lot of our like NSAIDs, a lot of our pain meds, a lot of our psych meds, a lot of our seizure medications. And then dialysis. So dialysis works through 3 ways. So we have osmosis, ultrafiltration, and diffusion. So dialysis is going to kind of take place of what our kidney's normal function is. Allow our kidneys some time to rest while also helping remove those waste products and excess fluid from our body. Osmosis is going to be our fluid removal, right? Fluid's going to go from a low to a high. So if we have an area that has a lot of water, has a low osmolarity, we're going to shift to the high osmolarity. So if we think about it like this is our lots of water, not many solutes. There's 3 little solutes there. Our membrane, not so much water, but a lot of solutes, super salty. Okay, we are going to have fluid shift from here to here. Okay, and then ultrafiltration is going to use pressure. So when we are dialyzing, we have fluid. Our diastolate goes one direction, not like the band. One direction. Oh gosh, that's awful. And then our blood is going to go the other direction. And again, we got a membrane here, semi-permeable, and that's going to allow for solutes and water to be kind of pushed through this membrane and into our diacylate, which is just going to be tossed out as waste when we're done. And then diffusion is through kind of like osmosis, but we're moving solutes in diffusion. Osmosis, we're moving water. Diffusion, we're moving solutes. So again, we got a whole bunch of gunk on one side. So this would be like our patient. Okay, patient is this gunky guy. Membrane to a not gunky side. Alright, our solutes are going to move from high to low. Okay, beautiful. Alright. So here's a picture of dialysis. So we can use their fistula. We can use a dialysis catheter. Alright, we're going to pull arterial blood. Okay, clean it. That's what our kidneys do. Our kidneys pull arterial blood, clean it, and then give it back venously. And then it's going to go back through the venous side, clean. This is our filter. Alright, and you cut your filter in half, and there's millions of these little membranes. Alright, where diacylate goes inside. Diacylate goes outside of the little tubes. In these little straws is where the blood goes, and this is semi-permeable in between, and we have osmosis, diffusion, and ultrafiltration to clean our blood. We can use this in acute kidney injuries, right, to rapidly clean blood and pull fluids. It is not a cure, though. It's just kind of a little band-aid. Okay, we still have to let those kidneys rest, treat the cause. And then here's just a picture of like what a fistula looks like, or a graft. We don't really see these in acute kidney injuries because it happens acutely, but we'll have this in an acute kidney injury, which is our temporary dialysis catheter, or a Merherker. If something has red or blue caps, we don't touch it. No, because that's a dialysis catheter. Alright, those are usually full of heparin, like 50,000 units of heparin. So if we've worked on the floor, we've had to give like 5,000 units of heparin, right? This is 10 times that in both sides. So it's a total of 100. That's a lot. So we don't touch them. And then CRRT. So CRRT is continuous renal replacement therapy. So we can again use this in acutely ill patients. Patient on CRRT is in the ICU. Alright, you are monitoring their hourly output to the mil, to the half of a mil sometimes. These patients we're also managing their electrolytes every 2 to 4 hours, depending on how sick they are. So it's slow and continuous, so it allows for a gentle resolution of like this acute kidney injury, gentle resolution of removing fluid and any waste products, especially for patients who can't handle like the rapid changes of hemodialysis. So in hemodialysis, we're cleaning 300 mils of blood a minute, where in CRRT, we're maybe doing that in an hour. Okay, we're going very, very slowly, especially for patients who are like really hypotensive or have some sort of hemodynamic problems, or worried about like their cardiac function. We'll do CRRT. So CRRT, so blood is pulled out, okay, and the necessary fluid and electrolytes are replaced to maintain stability. We can remove water and solutes very, very gently. It also uses ultrafiltration, osmosis, and diffusion. Also uses a hemofilter. Okay, it's going to use different types of diacylate that you're changing pretty often. So you change your diacylate based off of your patient's labs. Again, so you're changing these fluids every 2 to 4 hours. where hemodialysis, you're usually using the same exact fluids for the whole 4 to 6 hours every single time the patient's on dialysis. Where this, we're constantly changing based off of their electrolyte levels. And that is acute kidney injuries. If you guys have any questions, please reach out and let me know.